The topic for this video is orthodontics and medical conditions. An increasing number of patients with complicated medical conditions and drug regimes are seeking orthodontic treatment these days. So, progress in medicine and higher expectation of quality of life has has increased life expectancy, and orthodontists need to be aware of the clinical implication of these diseases. So these are the contents that we will be covering in this video. Orthodontists need to be aware of the possible clinical implication of these diseases. And in addition, orthodontists see their patients almost 6 to 8 weeks. They are exposed to the rapidly developing medical problems and which can manifest themselves at any age. So orthodontists need to be vigilant as they may be the only health professionals seen by otherwise fit young patients on a regular basis. The hematological disorders which are most common are sickle cell anemia and leukemia. So how would we diagnose people with hematological disorders? So a thorough history is very important, and if there is a bleeding which continues beyond 12 hours and requires a patient to call or return to their dental practitioner to seek medical treatment or emergency care. This also, if there is a resultant hematoma formation or ecchymosis within the soft tissue after any procedure, or if any blood support is required, then orthodontists need to take precaution before going ahead with the treatment. The considerations which we need to keep in mind is that if there are patients who are hemophilics and they come to our dental practice, that orthodontic treatment is not contraindicated, and they must be encouraged to maintain good oral hygiene, and atraumatic treatment should be carried out. Also, if there are patients with hemophilia, we should keep in mind that factor 8 should be supplemented, and we can give it in form of cryoprecipitate or fresh frozen plasma and purified forms of factor 8. Nerve block anesthetic injections are supposed to be contraindicated, so it's better to give infiltration. Fixed appliances are preferable over removable appliances. Self-ligating brackets are preferable over conventional ones, and we should take utter precaution while removing the arch wires so that there is no trauma, and duration should be kept to minimum. Now, sickle cell anemia is a genetic disorder which is usually characterized by hemoglobin gene mutation, HBS, as opposed to HBA. This restricts so there is reduced oxygen, deprivation of the oxygen in the blood tissues, because of which it causes deprivation of oxygen in the tissues, and there is intense pain. So it is more common in patients of African origin, but also occurs in Asian and West Indian descent. So the orthodontic consideration which we need to keep in mind, that the orthodontic forces should be reduced. Treatment is not contraindicated. Intervention is multidisciplinary. We should always consult a medical practitioner before starting the treatment, and we need to get the blood levels checked. Non-extraction approach should be preferred, and general anesthetics are contraindicated. Orthognathic surgery should also not be recommended. Now, leukemia can be of two types, that is acute and chronic form. Acute lymphoblastic leukemia, ALL, is the most common presentation in children, which amounts to almost 25% of the childhood tumors. The orthodontic considerations before diagnosis, we should see that there is usually significant orofacial complications of leukemia in children, and if we come across a patient with the major orofacial complications and we suspect that the patient has leukemia, we need to refer the patient to the physician. Now, most of the ALL patients have been seen to have reduced vertical dimensions of face, alveolar processes, as well as reduced sagittal dimensions of jaw characterized by mandibular retrognathis. Now, once it is diagnosed, orthodontic treatment should be postponed till the time the disease is in control. And if the patient requires chemotherapy as drugs and can exacerbate, because the treatment can exacerbate the thrombocytopenia and granulocytosis. After the treatment, it has been suggested that orthodontic treatment should be postponed for at least 2 years after the BMT. By then, the risk of relapse of the malignancy has diminished, and the patient is mostly no longer on immunosuppressive drugs. So we can carry out our orthodontic treatment. The treatment should be modified to reflect the patient's medical condition and planned with patient's best interest. Treatment mechanics should be aimed as such that there is a minimal risk of root resorption, keeping the forces low, and accepting a compromised treatment is better than reducing the risk of undesirable events.
Neurological disorders. It is important that orthodontists have knowledge of the most common neurological conditions, as some problems may manifest initially in the orthodontic chair. In this video, we will be talking about epilepsy, cerebral palsy, and multiple sclerosis. Epilepsy is a central nervous system condition in which brain activity becomes abnormal, causing seizures or periods of unusual behavior, sensations, and sometimes loss of awareness. Epilepsy can be seen in Down syndrome or in Sturge-Weber syndrome. Brain damage due to injury, infection, or brain trauma is seen in 25% of the cases, and 75% of the cases are idiopathic. Coming on to the orthodontic considerations, we should ask the patient if the patient has taken their medication and has eaten prior to the dental treatment. They should receive regular dental treatments to limit the dental diseases. The patient should be made aware of any injury that might occur and we should take consent. Gingival hyperplasia is seen in these cases. Removable appliances should be seen. We should ask them to carry mouth guard and keep benzodiazepine in the emergency kit. Phenytoin was once the first choice in managing epilepsy in younger people, but it has now fallen out of favor because of its many side effects. These include nausea, mental confusion, acne, hirsutism, hepatitis, rhythma multiforme, and gingival overgrowth, to name a few. However, the orthodontist may still encounter patients taking phenytoin. The alternatives, such as carbamazepine, have oral side effects of oral ulceration, xerostomia, glossitis, and stomatitis. Coming on to cerebral palsy. It is a group of disorders that affects movement and muscle tone or posture. It is of 4 types: monoplasia, hemiplegia, diplegia, and quadriplegia. Orthodontic considerations for cerebral palsy. We should take impressions which have quick set material. We should make easy bonding of the brackets. A self-etching primer should be used. Advanced memory wires should be used. Self-ligating brackets. Oral functionality should be seen. Advances in orthographic surgery and reversible mini implant anchorage. Multiple sclerosis is a demyelinating disease in which the insulating cover of the nerve cells in the brain and the spinal cord are damaged. The incidence is 1 in 1,000, and females have more predilection than males, that is 3:2. There is no cure currently for multiple sclerosis. The focus of the treatment is on the prevention of the disability and maintenance of quality of life. Drugs, physical treatment, and psychological techniques are used. The orthodontic considerations are: we should be aware of the trigeminal neuralgia for patients who are under 40. The treatment here is a multidisciplinary approach. Patients with dysphagia should not be treated in a supine position, but in a semi-supine position. The appointment should be made at the comfort of the patients. We should evaluate the removable appliances, and interarch traction are contraindicated. Next, we will talk about respiratory disorders. These are common, and the use of intravenous sedation and general anesthesia for elective procedures may be contraindicated. The unwanted effects of prescribed drugs can also influence the orthodontic treatment. Respiratory disorder, in here we will cover asthma and cystic fibrosis. Asthma, the severity varies from mild to severe. In moderate cases, episodes are severe, but the patients are symptom-free between attacks. In severe asthma, the attacks are severe and the child is never asymptomatic, and growth and lung functions can be affected. 300 million people worldwide affected by asthma. The influence of asthma onset and severity on malocclusion prevalence in children and adolescents. According to the present results, it can be concluded that asthma is associated to a malocclusion prevalence. There is no correlation between asthma severity and malocclusion. Asthma onset can influence malocclusion's establishment, especially when the disease is started at the first year of age. Coming on to orthodontic considerations. We should assess patient's risk level. A general rule is that elective orthodontic treatment should be performed only on asymptomatic or controlled symptoms. We should be aware of the dental materials and the products that we use if they can exacerbate asthma. In case of anxiety, which dental treatment causes, we should keep oxygen and the bronchodilators ready. Improper position of the suction tips, trays, and cotton rolls may cause symptoms, so those should be taken care of. An analgesic of choice here is acetaminophen. There is a tentative link to external root resorption with asthma. However, the root resorption was confined to blunting. Cystic fibrosis. It is the most common life-limiting childhood-onset autosomal recessive disorder among people of European heritage. It affects the exocrine glands of the lungs, livers, pancreas, and intestines, causing a progressive disability due to multisystem failure. The cells are relatively impermeable to chloride ions, and thus salt-rich secretions are produced. There is currently no cure for cystic fibrosis, and oral effects include hypoplastic enamel and delayed eruption. Orthodontic considerations. Consult the patient's physician to determine the severity of the disease. Local anesthesia should be preferred. Van Roo and Profit in 1985 said that salivary volume is affected. The submandibular glands are affected, which leads to increased risk of decalcification. Oral effects include hypoplastic enamel and delayed eruption.
Starting with ENT disorders. The disorders we'll be covering are airway obstruction as well as ear defects in cleft lip and palate. Coming to airway obstruction, in the upper airway obstruction, it can be due to viruses, any kind of inflammation, and it can also be a partial airway obstruction as well as a complete airway obstruction. Now coming to a deviated nasal septum, this leads to problems in breathing as well as sleep apnea, and patients usually complain of snoring. Hypertrophy of adenoids and tonsils. These are predominantly seen in mouth breathers. Enlarged tonsils. On the lateral cephalogram, as we can see, the tonsil extends posteriorly and inferiorly. The lateral cephalogram of 3 children with chronic mouth breathing showed different grades of airway obstruction. The first one shows grade 1, which is less than 50% of obstruction of airway in a girl aged 12 years and 3 months. The second one shows grade 2, which is more than 50% of airway obstruction, but less than 100% airway obstruction in a boy aged 4 years and 4 months. And grade 3, which is total obstruction in a boy aged 4 years and 9 months. The morphological characteristics of the long face syndrome in a 10-year and 10-month-old girl with chronic mouth breathing. The extraoral photographs can be seen here. They revealed lip incompetency, increased lower facial height, narrow nose base, and shadows under the eyes from chronic venous congestion. The lateral cephalogram of the same patient shows adenoid facies and a palatal plane tipped posterior inferiorly. Now, the treatment for patients with airway obstruction. Pediatricians and pediatric otolaryngologists should determine the optimal time of lymphoid tissue removal to enhance the nose breathing and prevent abnormal facial growth. The prevailing practice amongst the otolaryngologists is to delay the removal of the pharyngeal lymphoid tissues because of their role in the immunological defense. In peculiar adenoid growth between the ages of 3 and 16 years, that is, the increase in size is seen in preschool and primary grade years, followed by a decrease during the early adolescence. Now, coming to the ear defects in cleft patients, an association of the cleft palate with middle ear effusion is widely recognized. The cleft palate may lead to disruption of tensor veli palatini muscle, which plays a role in the function of the eustachian tube. Dysfunction of the eustachian tube increases the risk of serous otitis media. And more than 90% of the patients with cleft palate have middle ear diffusion.